Assalamu alaikum. It's a great pleasure for me to present this topic, Theodor Cocker's Theodor Cocker's to Professor Zafar Haider, the trait of great surgeons and how to inculcate in a young lot. History of thyroid surgery, ancient times. The thyroid surgery has been performed since the ancient times. In first AD Celsus, the Roman Encyclopedia reported the operation for removal of such a mass was dangerous. Al-Bukhasis, Abul Qasim, considered the father of the operative surgery in 11th century, also explained the removal of the gland. He is credited with the performance of first thyroidectomy along with the introduction of various surgical tools and probes. During the 12th to 16th century, various methods used in thyroid surgery led to serious intraoperative problems like hemorrhage, resulting in the imprisonment of a surgeon for this work. Over, Overall mortality of 40% triggered by the perfuse hemorrhage and severe sepsis led to the total ban on the thyroid surgery by the French Academy of Medicine in 1850. No further technical improvements occurred until the middle of the 19th century. Modern thyroid surgery, two prominent surgeons, Theodor Billroth and Theodor Kocker, proclaimed to be the father of the thyroid surgery, entered the operating theaters and changed the history of thyroidectomy. Theodor Billroth, the most distinguished surgeon of the 19th century, according to many medical historians, was appointed in 1860 chairman of the surgical department in the University of Zurich. In Zurich, he performed thyroidectomies, around about 60 thyroidectomy with a mortality rate of 40%. These disappointing results discouraged him and promoted him to abandon the thyroid surgery. Later in Vienna in 1877 to 1881, he decided to again operate on the thyroid surgery. This decision was promoted by this significant improvement in the antiseptics and hemostasis, and the result did justice to decision. He performed 48 thyroidectomy with only 8 deaths. Billroth was also an excellent teacher, and his pupil Theodor Kocker is clear professor of this. Thyroid surgery, as we know it today, owes too much to the a man, Swiss surgeon, the Theodor Kocker, born in Bern. He attended medical schools apart from a year after graduation. He visited various medical schools of Vienna, Paris, Berlin, and Vietnam. At the married age of 31, he became the professor of surgery of University of Bern in Switzerland and performed his first thyroidectomy after he became the professor of surgery. He was a quiet, serene, and rather austere man. Apart from his interest in painting, he decided he dedicated his life to the field of surgery. He was an exemplary teacher, technical surgeon, and keen a keen investigator. He made numerous contributions to the technique of thyroid surgery. He was a firm believer that thyroidectomy should always be performed in a bloodless field. He was a great dissector and practical anatomical dissector of the tissues. He performed 146 thyroidectomy from 1850 to 1877 worldwide with the mortality of 21%. He also reported 600 cases performed with half percent mortality in 1899-98, which revolutionized the technique and method of thyroid surgery. This earned him Nobel Prize for, for medicine in 1909, which constituted his great claim to the fame and the earned him the position of a leader in the field of surgery. The principle of thyroid surgery described by Theodor Kocker are still valid and became the foundation for all future refinements. Some Cocker's contribution to the field of medicine are as follows. Cocker's collar incision for thyroidectomy, that is a transverse incision. Before that, it was thought to be a vertical incision. Most of the surgeons prior to the Cocker exposure for thyroid surgery, they expose the thyroid gland by a vertical incision, which is now a ruthless incision for the exposure of the thyroid in a current practice. Cocker's method for reduction of the shoulder joint, Cocker's subcostal incision for the cholecystectomy, Cocker's incision for the exposure of the elbow, and Cockerization, mobilization of the duodenum, which is now known as the Cockerization of the organ, Cocker surgical forceps. Professor Zafar Haider, born in 1927, died 2017. I first met him as a medical student, then a house surgeon, then as a senior registrar, and ultimately as the professor of surgery. I have been in close contact with him for last 40 years. He was an institution from where I have learned a lot. I can surely say he was a great surgeon, superb craftsman, and a beautiful dissector with a thorough knowledge of regional anatomy. He operated with such immaculate precision and always maintained a bloodless field, ensuring complete compulsive hemostasis. He was a believer of the fact that the blood runs in the vessels, not in the tissues. He has he had a special interest in surgical oncology, head and neck, and endocrine surgery. He often used to say, which I would like to call pearls of Professor Zafar Haider. One, the first operation should be the last operation. It's a very important message for the young doctors. Nothing like the first operation. Nothing like a good operation. Never hand over a life to a surgeon which goes by watch. He introduced anatomical thyroidectomy in Punjab. The salient feature of thyroidectomy include adequate exposure by generous incision, Cocker's collar incision, from one external jugular vein to other external jugular vein, one finger breadth above the sternoclavicular joint and the two finger breadth above the suprasternal notch. Keeping in mind the incision is symmetrical, balanced with gentle convexity downwards. Stab muscle must be divided for a better exposure of the thyroid gland. He did not believe that the muscle gets atrophied since the nerve supply comes from below. At the superior pole, he tried he tied the individual branches of the superior thyroid artery. That is, one is anterior branch, other is posterior branch, and third one is the medial branch, which is called necklace branch. So individual ligation of the vessel at the superior pole of the superior thyroid artery and avoiding the injury to the external laryngeal nerve. Middle thyroid vein may be absent in 50% of the cases. It may be in 50% of the cases, it may be one or it may be two. You must create a space between the middle surface of the apical portion of the thyroid lobe and the pharyngeal wall. Inferior thyroid artery is identified in the perivertebral fascia in front of the spine, medial to the carotid. When I say carotid, it's a common carotid artery. It always enters the thyroid gland obliquely. Must recognize the inferior thyroid artery and tie it in the continuity. You will recognize the cross between the inferior thyroid artery and recurrent laryngeal nerve or its branches. Recurrent laryngeal nerve takes from below the inferior thyroid artery and may single or rarely branched below the level of the cross. No one knows which branch supplies the intrinsic muscles. Above the cross, you will find that the recurrent laryngeal nerve may divide into two or three branches, but it's difficult, rather impossible to appreciate which branch is carrying the motor fibers to the intrinsic muscle of the larynx. And this nerve enters at the inferior border of the cricothyroid muscle, and where the parathyroid gland is interior, posterior, the recurrent laryngeal nerve is anterior, and the superior parathyroid is posterior. That is the most important thing. Near its entrance, the relationship of the superior parathyroid is and and the posterior to the recurrent laryngeal nerve. The nerve is anterior and the superior parathyroid is posterior near its entrance into the larynx. Ligament berry is the only place the glands attach to the trachea where the damage to the recurrent laryngeal nerve is highly likely. When operating for the thyrotoxicosis, we can tie the main branches of both the sides of inferior thyroid artery as the gland is more vascular to control the hemorrhage. But when operating for a carcinoma of the thyroid or benign thyroid disease, you can tie the thyroid branches of the inferior thyroid artery and save the parathyroid branches of the inferior thyroid artery. Parathyroid glands are recognized by the color, which you will know by the period of time in a bloodless field. Try to work within the peritracheal fascia and avoid any extracapsular damage to the tissues. Drain placement is controversial. You never regret by putting a drain for 12 to 24 hours, but a drain never prevents hemorrhage, and the drain never works in the presence of hemorrhage. Once the once there is a hemorrhage, it is always recognized by the neck swelling and airway obstruction or stridor. We still follow in the footsteps of Professor Zafar Haider, my master, my mentor, who dedicated his life to his surgical profession. थैंक यू वेरी मच. अब इसमें कुछ थोड़ी सी चीज़ें हैं ना, वो ठीक करनी पड़ेंगी, मुझे सुनाई ज़रा. हो सकता है कल